Yes, sir. So the topic for my presentation today is arterial ischemic stroke in infants and children. Why I chose this topic is because when we talk about stroke, what comes to our mind is a population that majorly comprises of adult people and not a pediatric age group. With this presentation, I wanted to create an awareness that even children suffer from stroke, and the data shows that it's quite high as we think it might be, right? And there are certain challenges that come along with pediatric age group of stroke that I wanted to share with you guys. So here are some of the challenges that I found out while researching for my slides. First of all, there has been a clear lack of research and participation in clinical trials, which I think is because of the fact that children cannot consent for clinical trials on their own. They need a consent from their parents usually. And even when some states do allow research, it is, it is quite limited, and otherwise it's almost most states do not even allow children below 18 years of age to participate in clinical trials. Other thing is the immaturity of the blood-brain barrier, which makes it, really important that we monitor or follow up the child or the patient for a longer time as we would have with the adult population. And these follow-up needs to be more frequent because of the same reason. Other thing is that when an adult person suffers from stroke, there is they lose some part of their function, but there is still not as much difficulty in relearning the. For example, when an adult loses his, has a stroke, he has to relearn the experiences or the things that he used to do before. For example, we've seen people suffer from right-handed people suffer from stroke, and then they have to undergo rehabilitation to learn to write from left hand because their right hand is under paralysis or any such thing. But what happens in a pediatric age group is that they have difficulty achieving milestones, and there are functions that they have not yet learned, and they might not be even able to learn in the future because of the stroke attack. Research has shown that children who suffer from stroke lag behind in studies in their classroom. And not only that, I'll give you an example. Say a child suffers from stroke and his hearing is affected. He might not be able to attain his language proficiency as much as a normal child might have, who has not suffered from stroke. Other thing is the reoccurrence of stroke. There has been a higher incidence of stroke reoccurrence in pediatric age group as compared to the adult, which we will talk about later. And other thing is Reye's syndrome, right? When we talk about stroke in adults, we think about putting them on aspirin, but the same is not possible with the children. Although aspirin is still one of the best drugs studied and used in children for stroke, there is still a big high risk of Reye's syndrome occurring in children because of constant use of aspirin. So that's the sort of problem this this age group has. So while before we begin, I thought we should be on the same page regarding the definition. World Health Organization defines stroke as neurological deficit of cerebrovascular cause that persists beyond 24 hours. Unless it is interrupted by 24 hours by death, it will be referred to as stroke, right? And there, with the increasing amount of research, research and treatment, there has been a push to use the term acute ischemic cerebrovascular syndrome instead of the term stroke, to emphasize on the fact that time is of great importance while treating this. Here is some data which shows the incidence of burden of pediatric stroke. It is quite higher than we expect it to be, but what I found while preparing for this slide is that over the last 30 years, there has been an increased incidence of stroke. But then I researched further and I found out that this has been attributed to increased MRI, CT scan, and other diagnostic tools that are now used more and are easily available as compared to previous times. Now let's talk about pathophysiology. First of all, there could be a shock or some other, cause that results in diffuse hypoperfusion. What happens then is the areas which are known as watershed areas, which are already not well supplied are the ones that are affected the most. Other thing is there can be a thrombus formation or an emboli formation. The major difference in them being that when an emboli is formed, the symptoms occur maximum at onset, while when a thrombus is formed, a thrombus is gradually formed. The symptoms increase as the time of onset of stroke increase. Now, what happens in stroke? We can define the stroke on a scan by two different regions. Okay, the first region is where the maximum loss of function occurs. It is known as umbra, while the surrounding region, which is the penumbral zone, is the zone which can still be saved, and there is a reversible damage over there. So all our neuroprotective efforts will be focused on protecting this penumbral zone. Here is a diagram showing the major arteries which are usually affected by stroke and the cellular mechanism which occurs during a stroke. What happens is, with the loss of blood reaching the area, there is no glucose or oxygen supply. As a result, there is no energy for the cell to use. The sodium and calcium levels start to rise up as their pumps and sodium potassium pump and the calcium pumps fail, which draws in water. This results in cytotoxic edema, and the calcium can also lead to radical oxygen buildup, which can further damage the tissue surrounding. Damage to the lipid in mitochondria and lysosome starts, and the release of apoptotic enzymes leads to necrosis in the whole area. Now, this is just what happens at the cellular level. Another thing that I want to share is that once this cytotoxic edema builds up, there is a real risk of herniation. As the edema starts to increase and increase, pediatric age group has seen something known as malignant stroke edema, where there is a quite higher risk of brain herniation as compared to the adult population. Here are some of the most common causes of stroke. There are some hypercoagulable states like factor V Leiden, protein C deficiency, sickle cell anemia, migraines, moya disease, right? All these are common risks that the child is born with. And there's something really important that I want to share with you that I came across while studying this once again. So you see there are some conditions which lead to hypercoagulability in children and predispose them to risk of stroke, right? We can see factor V Leiden, or we call factor V Leiden, and protein C deficiency, which can create a hypercoagulable state and lead to increased risk of stroke. Now, this we know. Other thing is, when such a child who's already at a risk for increased stroke comes to you as a teenager for use of oral contraceptives, right, for their reproductive health, there is very less chance that you would recommend those use of those oral contraceptives to them, because that would increase their chances of stroke. And so while we talk about abortion, there has been recent debate that whether abortion should be allowed or not, and I'm in no position to comment on that, but I just want to say there are people who cannot use oral contraceptives because they are medically not eligible to do so. They put themselves in the harm's way just by using them because they already have a hypercoagulable state. So there are some people who we cannot even refer to use oral contraceptive, and that is something people should consider while talking about this. Other disease that I found interesting was a Mohammed Syndrome, and here's a case of a Mohammed Syndrome that I found I should share with you. Here is, you can see what is Mohammed Syndrome. First, I should say it is a progressive arterial disease in which the arteries start to narrow, and as those arteries narrow, a certain small tiny collateral starts to build up, and these collateral look like tuft of hair, which is Japanese for puff of, and moya is actually Japanese for puff of smoke, which we can see right over here. Okay, so here is a scan and angiogram of two children. One of them is the one labeled C is an 8-year-old boy who had hemiplegia, while her sister had complaints of headache, and that is the one we see on D, right? So both of them came and got diagnosed with Mohammed syndrome and later on developed stroke in their life. Here is another diagram of stage 3 cerebrovascular anatomy of Moya. So the clinical feature actually depend on what part of the brain is affected. Usual symptoms include aphasia, difficulty in hearing, hemiplegia, ataxia, abnormal eye movement, sensory disturbance, and vertigo. But it all depends on what part of the brain is affected the most. There is a mnemonic that I wanted to share with you. It is called FAST, which talks about the most common symptoms of stroke. So here it is. F for face, A for arm, S for speech, and T for time. Time just emphasizes the fact that we need to act quick to save more and more area while a stroke attack occurs, right? Diagnosis is basically, it should be clinical, but nowadays it's more and more dependent on radiology. MRI and CT scan are the major choices. MRI, although being the better choice, is not always available, so sometimes we have to go for CT. Another diagnostic test is FLAIR test, which can distinguish between FLAIR sequence test, which can distinguish between a new stroke and an older stroke. Treatment option includes thrombolysis, anticoagulants, antiplatelets, surgical option, and thrombolytics, right? But again, the biggest challenge is how, without much of research, we have to navigate through the limited options that we have. The basic TPA, transminogen plasmin activator, is not even well studied enough and is used off-label at most of the places. Not only that, just as I talked before, aspirin, which is the most studied and researched drug and has been in use for long enough, can cause Reye's syndrome in children. And, so we need to keep on following up with them. Any neuroprotective therapy is aimed at optimizing perfusion and oxygen to the penumbral zone, which we talked about earlier, and how what we can do is, just protect more and more area from getting infarcted. Surgical therapy, again, is one of the least studied options. Hemicraniectomy, which although has been found life-saving in some of the adult cases, has not been well studied in children. So is only recommended when the GECS score is rapidly falling and, goes beyond 5 in a pediatric age group. Goes below 5 in a pediatric age group. But here is another example of why pediatric stroke is difficult to treat, because there is no perfect dose for a child. There is no perfect, injection that you can create. You have to treat based on how old the child is, based on what the child age is, and how mature the blood-brain barrier would be at the time of presentation. So we have different protocol followed in various different areas according to the population of that area, which has been well studied. Okay, here is just one of low molecular weight heparin that I had shared, where the treatment varies depending on how old the child is, between months, and on how much the child weighs. Okay, so all this while I was studying, I found there has been a clear lack of research, and there has been, some sort of lagging behind studies between the pediatric and the adult age group. The stroke reoccurrence is higher in the pediatric age group as compared to adults. But again, this could be due to the fact that the child already had some pre-existing condition which predisposed them to stroke, right? As we talked about the hypercoagulable states which predispose them to stroke, there are also other obvious reasons that a child which has a higher potential of life ahead of him might suffer a stroke as compared to an old 80, 90-year-old person who has lesser years left comparatively. So one of the biggest morbidity that happens with stroke is paralysis, right? I'm sure we all have seen some patient of stroke who had permanent paralysis for the rest of their lives. So although there has been a lagging research, there is something new that I found is coming up. It is brain-machine interface, where actual microchips are inserted inside the brain, which help the patient to regain the function faster than they could have with therapy. And one of the most leading companies that is doing research in this area is Neuralink, right? So what Neuralink is doing, I thought I should be sharing this with you. And the CEO of this company is Elon Musk, as we might be familiar with. What Neuralink is doing is creating brain-computer interface. And what happens is chips are inserted inside the brain, and they do not even, and that those chips help to communicate and compensate for the lack of function that might have occurred due to the stroke. Elon Musk even goes ahead to say that that the patient will not even have to, get into a therapy after getting the surgical insertion of chips. He just has to think of what he has to do, and his body will do that. So maybe that is something that could cure paralysis for once and for all, right? Yeah, so thank you for your time, everyone. I thought this might create your interest in a pediatric age group for stroke. If you have any questions, feel free to ask me.
Okay. I stopped it right now. Stop.